In sepsis 3, the new definition, the intellectual construct of what septic shock is it is a subset of sepsis with an elevated mortality, secondary to a combination of cellular and metabolic abnormalities. So, two things intrinsic with that. The difference between the first one, the previous definition, and the new one, it's not just blood pressure.
I see.
So, and because if you take a step back and we ask, what is the definition of shock? So, what is the definition of shock?
It's end organ or malperfusion.
Inadequate perfusion, right?
Yeah.
So, does inadequate perfusion mean you have only solely cardiovascular disorder?
No.
No. You can have shock without low blood pressure, right? And you can have low blood pressure without any evidence of end organ dysfunction.
Right.
So when I was in the ICU a couple of days ago, I had a guy after carotid endarterectomy, and he was on a high-dose neodrip, and he was sitting there walking around, peeing, talking to me, and reading a newspaper. You make an argument that he had hypotension requiring pressors, but he didn't actually have any shock because I couldn't find any evidence anywhere to suggest that he had end organ dysfunction.
Yeah.
And so the new definition takes a couple of things. One is that it truly is more than blood pressure, and the other is that what do we really care about, even though this, you might make an argument this really doesn't belong in a definition, is mortality. So septic shock has a higher mortality. So then you get down to, just like sepsis 2, or sepsis 3 rather, our definition, life-threatening organ dysfunction secondary to a dysregulated host response to infection. How useful is that at the bedside?
I mean, that definition...
You can give me a number.
How useful is that?
At the bedside.
Like what % useful it is?
Yeah.
If you remember every single component, I'm sure it's high utility, but no one's going to remember that all those components.
Terry, what's the utility of the bedside?
0.
There's zero utility to the new definition at the bedside.
Okay.
It is an intellectual construct that defines something.
Yeah.
Just like the definition of an MI saying that you have inadequate blood flow due to a plaque rupture, leading to death of the myocardium, is of zero utility at the bedside.
Sure.
The utility you have at the bedside is your troponin is elevated, you have an ST elevation on your EKG, and they need to go to the cath lab. And so ultimately you have an intellectual definition that describes what something is, which is a step forward and is useful for research. But as clinicians, and I'm wearing this, I'm going to call this my doctor's white coat, not my scientist's white coat, it's totally useless to me, right?
Yeah.
And so I'm not going to see somebody and say, you've got a subset of cellular and metabolic disorders, any more than I'm going to say you have a plaque rupture with decreased flow to your myocardium. In sepsis 1, we had a definition, which actually wasn't a definition, but was of utility at the bedside.
It was a criteria.
It was a criteria. And so now in sepsis 3, do you know what the criteria are for septic shock?
I don't know what the defined criteria are now.
Okay. So what we did when we went into this is we looked at this, and I'll say that this is a spoiler alert because this is controversial in the ED community. This is one of the things that was controversial. We went in and we said, what are the things that you can use potentially to look at somebody in septic shock that would be useful at the bedside? So what would the things you might want to look at?
So their vital signs. We've talked about respiratory rate before.
Okay, but we're just talking shock now.
Okay. At the bedside, what would I look for?
Yeah.
Blood pressure.
Blood pressure.
Skin turgor, how cool or warm they are. Whether they're making urine, and their mental status.
So we tried to make this one even simpler. So unlike sepsis 3, where the clinical criteria, where we ended up using the SOFA score, and we talked about QSOFA last time.
Yeah.
And we looked at 23 different things to ultimately come up with QSOFA.
Mm-hmm.
Here we a priori basically said we're going to look at 3 and only 3 things. We're going to look at blood pressure, low or not low. We're going to look at need for pressors, yes or no, with the understanding that's not exactly the same thing as blood pressure. They're similar. And what is the one blood test you typically look at to see whether somebody's in shock, to see whether they're perfusing or not?
Their creatinine.
Nope. What, dairy?
ABG.
Lactic acid.
They're lactate. Okay. And so we basically said a priori we're going to bunch everybody from a database of millions of patients, and we're going to do the same criteria we previously had for identifying sepsis. That is, somebody had to have a suspected infection, and you suspect infection by somebody sending cultures and starting antibiotics and continuing antibiotics. And so if you send blood cultures and you start antibiotics and you continue them 3 days later, you have to assume that somebody suspected infection. And so you take a whole group of people with suspected infection by a post hoc chart review, and then you say, we can bunch these into people who were hypotensive but not on pressors with not an elevated lactate, or an elevated lactate but normal blood pressure and no pressors, and you can bunch them into every single different group.
Okay.
And ultimately, you can sort of make it down into a very straightforward of what counts as septic shock. And this, by the way, was not unanimous, but the thing which is published in JAMA is that clinical criteria for septic shock are a combination of hypotension plus the requirement for vasopressors plus a lactate greater than 2.
So that's sort of a stepwise progression, because why do you divorce hypotension from the need for pressors?
Divorcing hypotension from the need for pressors is just simply that nobody's going to leave somebody hypotensive and leave them off pressure. So you're not going to say, so even though they're intellectually different, they're functionally the same. You're not going to say, I have somebody who is a MAPA 45 and I'm not going to start them on pressors because I want to see what the natural progression of having a MAPA 45 is.
Correct.
If you adequately fluid resuscitate somebody and they're hypotensive, you're going to start them on pressors. So functionally, you can say it's the same thing. In actuality, there really were 6 groups when the analysis were done, but there were such small numbers in a couple of groups that you really ended up with 2 basic components. What is your mortality with hypotension / pressors alone, but a normal lactate? What is your mortality of an elevated lactate but a normal blood pressure? And what is your mortality of the combination of hypotension and pressors plus an elevated lactate? And I do want to emphasize here that the elevated lactate is greater than 2.
Okay.
Not greater than 4. So if you look at the surviving sepsis bundles, or for people who are going to be practicing the community next year when they're actually going to get dinged on this for quality control by the federal government for the SEP1 measure, it uses a lactate of greater than 4. But here it's a lactate greater than 2, and there's a reason behind that which has to do with mortality.
The studies are with the lactate greater than 2 is what you're saying?
Well, the sepsis 3 definition is lactate greater than 3.
Okay.
And the rationale is we actually looked at each lactate level, and the lactate level that actually gave prognostic information was greater than 2.
Okay.
So while you do have a slight increase in mortality if your lactate is greater than 4 versus greater than 2, the key thing to remember here is that a lactate greater than 2 is not normal. And you wouldn't say, oh, the lactate's 2.7, we're good. It's actually a problem. So you take them together, and the truth is, when you take your definition of sepsis, again, retrospective with all the limitations that come into a retrospective study, if you look statistically, there's not a significant difference between hypotension with normal lactate and sepsis with organ dysfunction. That gives you hypotension with normal lactate, pressors, normal lactate, gives you a mortality of about 30%.
Okay.
Elevated lactate, normal blood pressure, which is something that a lot of people in the ED feel very strongly about, represents shock, gives you a mortality of 25%. Definitely not like a negligible thing.
0, yeah.
So in an isolated elevated lactate, a lactate of greater than 2, gives you a mortality of 25%. So I'm not going to sit here and say, oh my God, that's normal. If you see a lactate of greater than 2, that is a medical emergency. That is somebody who has a 1 in, if you suspect infection, that is somebody who has a 1 in 4 chance of dying. But it doesn't particularly discriminate mortality from somebody who has suspected infection plus organ dysfunction.
Right.
If you take the 2 of them together, if you now take hypotension / pressors plus an elevated lactate, your mortality is 42%. Significantly higher for each. And because of that, the new clinical criteria for septic shock are the combination of hypotension / pressors plus an elevated lactate. So if you're at the bedside and you see somebody who's on pressors and their lactate's normal, it doesn't mean you're like, oh, they're fine. They still have a mortality of 30%. And if you see somebody in the ED with a lactate of 2.7, you don't say they're fine because their mortality is 25%. But the combination is not going to be appreciably different just from seeing somebody with organ dysfunction and suspected infection. If you see those 2 of them together, the easy thing to see at the bedside, they're hypotensive, they're on pressors. And the thing that you can see at the bedside, which is their lactate level, you have to get it as a blood test, which is not the same as cellular hypoperfusion, but is a reasonable surrogate for anaerobic metabolism. You take the two of them together, and you now have a mortality of 42%. That person has a nearly 1 in 2 chance of dying.
I see.
That's the new clinical criteria. And then how do you treat people differently with septic shock versus sepsis?
Shock versus sepsis?
Yeah.
I mean, besides treating them with antibiotics, you may be on pressors, and you transfer them to the ICU.
It's a
They're
trick
in shock.
question.
I guess it's not really that different.
It's a trick question. You don't treat them differently at all. So this has prognostic information, but ultimately we're trying to teach people how to take care of patients, and the truth is, you don't treat them any differently at all. All the sort of things that one does to take care of patients, the rapid antibiotics are the same thing.
Mm-hmm.
The data are stronger for septic shock. The data that I've quoted, that for every hour you delay antibiotics, mortality goes up by 8%.
Mm-hmm.
That's in septic shock. And that gets like a 1B recommendation. The data for sepsis, previously severe sepsis, is a 1C, but it's generally similar data. The antibiotics are the same. The amount of fluid you give them is the same.
Mm-hmm.
Everything is the same. The only difference is if their blood pressure is low, you give them pressors. Just like if you can't breathe on your own, you give somebody a ventilator.
Sure.
But other than that, the treatment for sepsis is identically the same. So it doesn't matter which definition you use. To some degree, it has to do with prognosis. So the only difference that might make a difference to you, and it might not, is your sense of urgency. Because if you have somebody, if you have somebody that you can say, this person has a mortality of over 40%, that should be setting up every kind of alarm bell imaginable in your mind. And I'll go back to what I've said before to get on my soapbox. The mortality for sepsis, just sepsis without shock, is higher than the mortality from a stroke, higher than the mortality from a heart attack, and higher than the mortality for a trauma. And yet nobody sees somebody in the ED and says, it's a trauma, I'll see him in a couple of hours. And nobody says, it's an SD elevation MI, that's a call, I'll eat lunch, I'll do something else, and I'll come back and I'll make sure they get to the cath lab. If they get to the cath lab in a couple hours, that's all good.
Mm-hmm.
But the mortality for septic shock is over 40%. It's higher than the mortality for any of those. And we know that the simplest thing possible, it is way simpler to give somebody antibiotics than it is to take somebody to the cath lab, than it is to take somebody to do a trauma resuscitation and get them to the operating room. But for every hour we delay, the mortality goes up by 8%. So in that sense, it's different because it makes you, perhaps if I'll have alarm bells go off in your mind, but the truth is, it is to some degree an arbitrary distinction that we can't really make the distinction scientifically other than just to say there's a difference in their blood pressure and the lactate. They're sicker people do worse. How do we treat them? We treat them exactly the same.
How do you define hypotension?
Depends on the study. It's going to be a systolic blood pressure of less than 100, or a systolic blood pressure of less than 90, or a MAP of less than 60, or a MAP of less than 65. Mm-hmm. Functionally, those are all going to be pretty much the same. So for some of them, it's actually explicitly stated what it is. It is a systolic blood pressure of less than 100. It is a MAP of less than 60. And for some of them, for the previous sepsis definition, it just says hypotension refractory to fluid resuscitation requiring the need for pressors. And I guess I'd make the argument that it doesn't really matter whether your MAP is 61 or your MAP is 59 and you're on 0.01 Alevo or you're not. To me, that's similar to the blood transfusion studies. There's clear data on 7 versus 10, but there's no data on 6.9 versus 7.1. It's an arbitrary distinction. And somebody who says, no, I'm not going to transfuse because their hemoglobin is 7.1, and the next day says, I'm totally going to transfuse because the hemoglobin is 6.9, it's basically the same thing. So whichever trigger you use, and the truth is the thing that perfuses your body is the MAP. And so I'd make the argument optimally you'd actually use the MAP of less than 60 or 65. But if you want to use a systolic of less than 100, which is what's in QSOFA, by the way, that's fine too. Ultimately, you're looking for something which is different and low. And if you take, and even though it might not sound terribly low, of the three of us here, the person who statistically should have the lowest blood pressure should be Priya, by gender. And so what's your baseline blood pressure?
It's 100 over 60.
100 over 60. And so if you remember your formula for blood pressure, it's 2/3 diastolic plus 1/3 systolic. And right, so 100 over 60 is 120 plus 100 is 220 divided by 3. So your MAP at baseline is 73. And you are going to be younger and healthier than basically every single one of your patients. And so if you had a MAP of 60, that would be frankly hypotensive for you,
Mhm.
because 90 over 60 doesn't give you a MAP of 60, because by definition your systolic is 60. And so your blood pressure would have to drop very significantly, and most of our patients don't have baseline blood pressures of anywhere around 90 over 60.
Mhm.
I'm older than you, obviously, and my blood pressure is not 90 over 60. It's pretty good. It's probably like 110 or 120 over 60 or 70, which
Yeah,
probably
it's
gives
really
me
good.
a baseline MAP of around 80 or 85.
Mhm.
I'm not hypertensive. I'm not on any medicines for it. But if I had a MAP of 60, I'd be profoundly hypotensive for myself.